Glaucoma is a disease of the optic nerve, often associated with high pressure. The problem with glaucoma is it doesn't have any symptoms. It is often called the silent thief of sight. And what happens is if the pressure is slightly elevated and you don't know it, the pressure will gradually cause cell death within the eye and lose tissue that we depend on in order to be able to carry the vision from our eye to our brain. Sometimes we actually discover glaucoma in a quite advanced stage simply because we didn't have an opportunity to screen or do preventive eye care. It's kind of like high blood pressure. So if you have high blood pressure and you go on to develop heart disease associated with it, you might be able to be saved by having a stent placed in your heart or cardiac bypass surgery. Unfortunately, in glaucoma, if we don't get to the area that's damaged before it gets damaged, there's no reversing the loss. So even more important than cardiovascular disease, we have to prevent the loss if we hope to be able to help people maintain vision for their entire life. There are multiple risk factors for people who have glaucoma. The most important risk factor is elevated intraocular pressure. Additional risk factors include a strong family history of glaucoma, especially if somebody has lost vision from that. Second thing is race. It's fairly common in the Asian population and in the Black population. It is also gets more prevalent as we age. For instance, if you're under 40 years old, the incidence of glaucoma is less than 2%. But if you're over 75, 8% of people actually have glaucoma. Everyone in our office, on almost every examination, unless you are acutely infected with a pink eye or something, we check the pressure on everybody all the time because we never want to miss that. In addition, I almost always check the health of the optic nerve at any visit that I have, also because I don't want to miss anything. We actually use a couple of different devices. The most common is something called the tono pen, and it actually gives us a reading, and we're able to put a little sheath over this device and gently touch the numbed eye so that we can get a pressure. And this is all computerized and takes 10 readings in a matter of a few seconds. We detect an elevated pressure. One of the doctors in our office will then do a comprehensive evaluation to determine why the pressure is elevated, and will actually test you again to repeat and make sure that the pressure is actually elevated. When we are testing somebody for glaucoma, we start with just a general evaluation of the eye. Then we check the drainage canal, because if you think about it, glaucoma is a balance of what we call the intraocular pressure. And that is determined by the amount of fluid made inside the eye balanced against the amount of fluid that drains out from the eye. We then evaluate the health of the optic nerve. We will evaluate the function of the vision using a test called a visual field test. We will take a photograph of your optic nerve so that we can see and magnify in high detail whether or not there's any abnormality there. And then we do a test called an OCT, which is called optical coherence tomography, kind of like a CAT scan of the eye done with light instead of radiation, and it helps us measure the health and well-being of the optic nerve. So the amount of testing that goes into determining whether somebody has glaucoma is highly impressive and getting better every day. So what we're looking at here is a photograph of the optic nerve. And what we look at here, this is the optic nerve, and the red lines coming off of the arteries and veins. The optic nerve kind of looks like a donut, and in glaucoma, the hole, or the donut hole, gets bigger and bigger. So what we're managing or monitoring is change within this structure. With this camera that we have, we can actually measure the exact size of that optic nerve and repeat it from visit to see if it's changing. Having done fellowship training in glaucoma at the University of Pennsylvania, I learned at that time, more than 30 years ago, that if you think you can easily control glaucoma, you may be mistaken. On the positive side, glaucoma management today is so much better than anything we've had, and there's an absolute explosion within the field of ophthalmology of different treatments and different modalities to help make glaucoma treatment better. And I must say I'm very excited about the prognosis for those of you who may be suffering from this very challenging condition. You can use either eye drops, oral medication, oftentimes laser, where we clean the drain with a laser, and then in more advanced cases we actually do different types of surgical intervention to create a new drain when we can't make the drain work well enough. There are two types of glaucoma lasers. One is to make the drain of the eye deeper. That's called a laser iridotomy, where we use a laser to poke a little tiny hole in the blue or brown part of the eye so the fluid can flow from the back of the eye to the front of the eye. That's done for people who have a condition called narrow angle glaucoma. Another procedure we do is called an SLT, or a selective laser trabeculoplasty. That's a mouthful, that's why we call it SLT. But what that does is we utilize about 100 laser shots to help make the drain work better. And what happens is it's kind of like putting Drano in the drain of your sink. It actually gets fluid to flow through it better. In almost all cases, we perform the laser right here in our office. When we do a laser, be it an SLT or an LI, often patients drive themselves home and there is virtually no downtime. You will be blurred for a few hours, and we only do one eye at a time, but there is no downtime from it. We'll give you some eye drops to use just for 2 or 3 days to make the eye feel better, kind of like eye aspirin. But again, no downtime, and not that there's no risk, but virtually no risk. But my personal advice is everybody who is careful about their vision should make some effort to have a comprehensive eye exam at some point, maybe in their teenage years, then maybe again in their 20s. And if they have no visual problems, it's reasonable to have your eyes checked every 1 to 2 years to make sure that something isn't going wrong. Glaucoma is a complex group of diseases. It's not a disease. Second thing we understand is each one of them responds differently. But given the modern techniques, our #1 goal is to find it early. And if we find it early, we can stop its progression.